Good evening, everyone. I'm Dr. Harita Isnak, member of FCPI. It is my utmost pleasure to extend a warm welcome to every one of you. Today marks a significant moment as we gather here for the basic module presentation of the Research and Publication Forum, titled The Basics of Evidence-Based Medicine, Part 2, by the esteemed Muhammad Rashid sir. In an era defined by rapid advancements and an ever expanding body of medical literature, the concept of evidence based medicine emerges as both a guiding principle and a necessary framework for clinical decision making. Our objective is to deepen your understanding in how to use solid evidence to make better healthcare choices. By discussing and analyzing research in an easy to understand way, we are building up our knowledge to confidently handle healthcare challenges. Before moving on to the session, I would like to give you some participant guidelines. Moving on to the slide, first one. First point I have to share is post your questions. Type your questions or responses in the comment box and click the submit button. Your questions will be discussed during the QA session at the end of the session. The next one is submit your feedback. Feedback button will be available below the comment box. Feedback form will be disabled after the live session. So make sure that you are giving the feedback during the session itself. The next one is claim your certificate. Certificate of attendance will be issued within 14 days after attending the event. If you're watching the event on YouTube, please log in to our website and register for the event to claim your certificate. And the final, download your slides. Whatever we are doing in this session, all the study materials are freely downloadable. So presentation slides PDF can be downloaded from the website directly. Login is mandatory to download the file. Okay, so moving on to the session, I welcome Mr. Muhammad Rashid sir, who will take us through this enlightening module. Sir is the Vice President of FCPI, a Senior Research Fellow of INSPER under the Department of Science and Technology at Manipal Academy of Higher Education. Sir has published more than 80 papers in national and international journals. Sir is also the regional lead of the Student Network of International Society of Pharmacoeconomics and Outcomes Research, ISPER, for the Asia Pacific region. Without further ado, I would like to invite Rashid sir to begin with the session. Over to you, sir.
Thank you so much, Harida, for the warm introduction. And thank you everyone for joining today's evening for the second module of Basics of Evidence-Based Medicine, which is hosting by Research and Publication Forum of FCPI. So as Harida was discussing, there are multiple activities have been running by FCPI different forums, and we invite all the students and the freshers and all the professionals to go through the sessions to get a newer learnings and update about clinical pharmacy and different aspects through FCPI. So I'm just moving to my session, and the last session which had in the last month, we have already covered the basics on what is an evidence-based medicine and what is meant by evidence-based practice and how you can incorporate basics of medicine or evidence-based medicine into the practice. Then we have discussed what is a clinical guideline and how to interpret an evidence through the clinical guidelines. Then we have explained what are the different grade recommendations and quality of evidence classification to grade your all the evidence before you incorporate that into your clinical practice. So this was the discussion which we had last week, and we have given few basics on what is a study design and what are the different study designs. But in this session today, we will be more discussing on what are the different study design which we are using in our daily clinical research and clinical practice. So we'll be discussing what is the different advantages and disadvantages of basic research designs in the clinical research. Then we'll be just looking into different glossaries or terminologies which we are using in the clinical trials. And then we'll be discussing on an introduction to the risk of bias and what are the different assessment of risk of bias tools. Then we had a discussion in the last class as well. We discussed what is an important of the risk of bias. Just today, again, we'll be giving an in-depth understanding on risk of bias, because risk of bias is very important when you get into the evidence-based medicine into the practice. So anyway, in the coming slides, we'll be discussing in depth on that. So moving forward, so basically there are different types of study designs. So I'll start with the highest level of evidence. So last class, when we discussed Oxford criteria for level of evidence hierarchy, we told that systematic reviews and meta-analysis are the topmost evidence which we use in our daily clinical practice or under the umbrella of evidence-based medicine. So basically, we should understand what is the difference between a systematic review and a narrative review. So basically, whatever the discussion, whatever the studies or whatever the reviews which you do in your daily activities, suppose you are a student of PharmD or MPharm or you're a student of a research student, so you will be asked to do many kind of literature reviews. So let it be for your thesis work or let it be for your protocol or any aspects you will be asked to define or you will be asked to write a simple review on a particular topic. So basically, what you do, you will go back to the literature, what is already published on that particular topic. Then you will be taking some information from that. Finally, you'll be summarizing all those information. So that kind of traditional way of literature review is called it as narrative review, or more often nowadays we call it as a traditional review or conventional review. But the last few years or over the decade, there is a proper systematic way to do this particular review. Then that when you are following that proper way of doing a review, that is referred as a systematic review. So that is basic difference between a narrative review and a systematic review. So here I'll be just giving some insight on what is the difference between a narrative review and a systematic review. So basically, in narrative review, as you know, there won't be any protocol, there won't be any methodology. You will be having a topic, you'll be just doing some search, let it be maybe in the Google or Google Scholar or PubMed. So you'll be just taking some articles, you'll be just doing a narrative summarization of what those articles are talking about. But when it comes to a systematic review, there is a proper pre-specified methodology. That's very important. It is not making when you are doing it. No, you are doing pre-specified methodology, and you will have a proper protocol which is registered in the protocol registry. Then you will be following that proper way of doing a narrative review. Then that is referred as systematic. So the first difference between a narrative review and a systematic review is the protocol or predefined methodology. So as I mentioned in the narrative review, what we are doing, we are just going to the just some databases or some Google or any other resources which is available. We'll be just taking some articles, so it is very limited. But when it comes to a systematic review, you will have a proper comprehensive search. So you will be searching for all the published literatures, you will be searching for all the unpublished literatures. So we may have in the future very specific sessions only on systematic review. So we'll be talking in depth about what is the difference between a published literature and an unpublished literature, how you can access a published literature and how you can access a unpublished literature. So that is, you just understand that is another difference between a narrative review and a systematic review. So the other thing is that in a narrative review, you won't be doing any risk of bias assessment, or in other terms, you will not be checking the quality of the evidence. But when it comes to a systematic review, you will be properly analyzing the quality of evidence. You will be grading the evidence, then only you will be taking forward. So that is another difference between a narrative review and a systematic review. So one point which I just want to mention here, sometimes the authors will mention that it is a risk of bias assessment. Sometimes they will say that it's a methodological quality assessment. Both terminologies are correct. You can use either it is a risk of bias assessment or you can say that it is a methodological quality assessment. So it is methodological quality, not reporting quality. So there is another aspect on that. The next one, what we usually do whenever we do a narrative review, we'll be always relying upon just p-value. I'll just say that on a particular topic, the ABC et al. Or so and so et al. Reported that the drug A is comparatively better than drug B, or drug A is significantly better than drug B, p-value less than 0.05. So you will be just over relying only on p-value to decide whether that particular intervention is effective or not effective. But when it comes to a systematic review, you will not be only relying upon a p-value. P-value is not only the statistical measure or effect measure to make a decision. There are multiple other effect measures. You can check into the effect measure like odds ratio, hazard ratio, or you will have relative risk, and you should check whether they have used it properly or not. Along with that, along with the p-value is one of the aspect of that measuring whether the treatment is effective or not. Along with the p-value, you'll be looking to the confidence interval, or you'll be looking to the credibility interval, or you'll be looking to the inconsistency, you'll be looking to the heterogeneity. So there are multiple other factors which will decide whether your intervention is effective in that population or not. So there is another difference between a narrative review and a systematic review. Then in the narrative review, you will be following a vote counting method. Vote counting method means whatever the study design which you got, whatever the studies you got, maybe it's an RCT or it may be a case report, it may be a case series. So with different set of study designs. So what we usually do in a narrative review, you will be making a club of everything, or you will be just blending all the different designs together. Like I don't say whether it is from a RCT or it is from a quiz report, or I don't check whether it is having a more weightage than the other one. So what we usually do in a narrative review, we just keep on summarizing and going on. So that is called as a vote counting method or vote counting method. But when it comes to a systematic review, you will be properly assign a weightage. Each study will be given a weightage. Suppose I say one simple example. Suppose you have two RCT and one RCT is having suppose more than 1000 participants and another RCT is having just 100 participants. So if it is a narrative review, you won't give any difference between the RCT number 1 and RCT number 2. But when it comes to a systematic review, the RCT which is having a higher sample size is always have a better value than the other one. So here what I'm doing, I'm giving weightage to one study over the other study. So it is one example which I given based on the sample size. There are multiple methods to give the weightage, multiple ways to give the weightage. Basically, in a systematic review, you will be giving a weightage to each study, which is not there in a narrative review. Then narrative review will be always descriptive, or sometimes we call it as its qualitative synthesis, but systematic review will be quantitative sometime, not always, sometime. So sometimes even the systematic review can be a narrative review, but it will follow the proper methodology. So basically, it will be descriptive sometime, or it can be quantitative when you do any kind of meta-analysis in that. So I'm not getting into the meta-analysis right now because if I start talking, we have all of a different session on that. So you just understand that whenever you do any quantitative estimation or numerical assessment, then it will be called as meta-analysis. And this meta-analysis is part of a systematic review. So that is another difference between a narrative review and a systematic review. So next one is about the bias. So narrative review means you are doing your review, you are just summarizing the evidence. So as a single researcher, there is a chance of subjective inclusion of evidence or the kind of subjective interpretation, I could say, in a better terminology. So it is called as bias. So suppose I want to favor my drug. Whenever I write a narrative review, there is a chance that I will only take those studies which are favoring my result. So what I'm doing, I'm doing a bias there. So that is what happens when it is a narrative review. But when it comes to a systematic review, the bias will be completely avoided or bias will be completely removed in a way that in a systematic review, it is minimum requirement that you should have minimum two independent reviewers who will be taking care in all the stages of this review process. So what happens, suppose if I want to include one study also, there is another independent reviewer. He will be cross-checking the data which I did. So there is a chance that the bias which I am going to induce will be removed from the process. So basically, in a systematic review, it is more unbiased information. It is more of objective information. It is not a subjective information. So that is the another reason why we are taking the systematic reviews as the top of the evidence in a level of hierarchy of evidence. So this is some basic understanding or basic difference between a narrative review and a systematic review. So this is the first study design when you talk on the hierarchy of level of evidence. So I'm just moving to the next slide. So I hope you guys have a small clear idea on what is the difference between a narrative review and systematic review. Hopefully, in the future sessions of FCPI or the other sessions, we will have more in-depth information on different study design. So we may have more sessions on this aspect in the future. So the next session, as I just mentioned, meta-analysis. So basically, as I said you that whenever you do a quantitative estimation, whenever you do a numerical assessment, then that is referred as a meta-analysis. So basically, I have the data from I have a data from 5 to 6 studies which are having some kind of criteria is assigned. So I have the data from 5 or 6 studies. So what is happening here? Suppose for the first 2 studies are telling that it is effective, and next study is telling that it is not effective, and another 2 studies telling that it is effective but not significant. So what is happening here? There is a different conclusions. There is a different conclusions, or there is a conflict between these studies. So here, what I'm doing through the meta-analysis, I'm going to pool all the results from individual studies. I'll be applying some statistics into that. Then I'll be trying to collate all this information into a single estimate. So finally, the single estimate I'll be selecting, and then I'll be deciding whether that effect is effective or not effective or not significantly effective. So basically, I'll be applying some statistical measures to pool all these different results into a single estimate. That process is called it as meta-analysis. And be clear, this meta-analysis will be always a part of systematic review, but it is not mandatory that all the systematic review will have a meta-analysis. So it depends on the data, what you get at the end of the study. So just have an understanding that, because you will not be able to tell in the start of a systematic review whether that systematic review will be a meta-analysis in the future stage or not. So only you will be able to getting to know that at the end of your systematic review. If you have a numerical data, if you have a quantifiable data, then you will go for meta-analysis. If not, you will be just restricting to a systematic review. So that's about the meta-analysis. Then there are 2 plots in a meta-analysis. The first plot is called it as forest plot. So this is very important when you learn about meta-analysis. And I got to know that even this will be asked in many competitive exams also, like your board examinations, BCPS, and all the other things. I got to know that this is one of the mandatory questions to interpret the forest plot or meta-analytic results. So it's very important. So this forest, the left side of the screen or right side of the screen, that is called as sorry, the right side of the screen, the left side of me, that is called as the forest plot. So the forest plot typically will have a x-axis and the y-axis. So the y-axis and x-axis. So what is happening? The effect measure will be given. So you can see here. Suppose here there are 5 studies. So first study, second study, third study, and fourth study, and fifth study. So there is a diamond. This diamond is the meta-analytic result. So what basically I did, I have pulled from all these 5 studies, and I have a diamond. That is the final result of the meta-analysis. So I'm not getting into the interpretation of that. We may have that in maybe in the future classes. So there is another plot on the left side of the screen, that is funnel plot. So funnel plot basically we use to analyze the publication bias. So there is some interpretation for that. Even that also will be in detail explained in future classes. So basically, I just want to inculcate a knowledge that there are 2 type of plots in a meta-analysis. One is forest plot, Another one is a funnel plot. So now there are so many other study designs. So I'm just discussing one by one. So you can see this after a systematic review and a meta-analysis, the next level will be a randomized controlled trial. So randomized controlled trial, as you all know that it will be a prospective study design. Prospective study design means you will be starting the study from now and you'll be following your patients for future. So that design is called as prospective study design. So basically, all the randomized controlled trial will be prospective in nature. Then there will be a comparator always because you'll be randomizing the patients into two groups. One is your intervention, another one is your comparator. So always there will be a comparator. So always the RCTs are will be comparative in nature. Maybe this comparator will be a placebo, or it will be comparator will be a no drug, or the comparator will be any other drug. So anything will depends on your research question. So you will be having a comparator. So basically all the RCTs are comparative in nature. It's a quantitative estimation. RCTs are always quantitative. Means you will have numerical assessment. You will have numerical data to be assessed. Maybe in terms of categorical outcome, or in terms of ordinal outcome, or in terms of any kind of survival outcome, or in terms of any continuous outcome. So basically, you will have a quantitative measure in the randomized controlled trials. It will be experimental. Experimental in the sense you will be studying the effect of a new drug, or you will be altering the ongoing therapy of the patient. So always it will be experimental. So it's not observational, it will be experimental. That means it will be interventional in nature. So it will be in a controlled condition. Controlled condition means you will be setting the specific inclusion and exclusion criteria to take the participants into a study. That is meant by controlled condition. Random allocation of the groups, like I said you, when there is a randomization process is involved, all the participants will be given equal chance to distribute either to the randomized group, or either to the intervention group, or to the control group. So basically there will be random allocation, and that process is called as randomization. Suppose sometime you can do a interventional study without a randomization also. You can group the patients into intervention and control, but there will not be any process of randomization. Then it is called as non-randomized interventional study or non-randomized controlled trial. So that is called as NRCTs. RCTs and NRCTs. The only difference is in terms of randomization. Then RCTs are always most rigorous and robust in nature. Then, as I mentioned, there are multiple terminologies which come to the RCT, randomized controlled trial. First one is randomization. So don't get confused. Always the students or those who are involved in the research will be getting confused between a randomization and allocation. So basically, randomization is the process of grouping the participants into intervention and control. That is called it as randomization. And this randomization is having multiple methodologies. It can be a simple randomization, can be a cluster randomization, it can be a stratified randomization, or it can be a block randomization. Even sometimes it will be a cluster block randomization, or there will be a stratified block randomization. So you can use any multiple approaches for that. So basically, randomization is the process of dividing, process of grouping the patients or participants into the intervention and control. That is referred as a randomization. There is a process of allocation. The allocation, many people will get confused between a randomization and allocation. So basically, allocation, now the randomization process is done. Allocation means you are allocating the treatment into the participants. So not allocating the patient into the group, allocating the treatment into the participants. So now one participant is there in the intervention group, another participant is there in the control group. Now what you are doing, you are giving the intervention drug to that participant who is already randomized into the intervention group. That process is called it as allocation. you might be studied different methodologies for this allocation. There is a computer based allocation is there, or phone call based allocation is there, sender allocation is there, or sometimes you call it a sequentially numbered envelope method for allocation. So there are multiple methods for this allocation. Then there is a blinding. Blinding means you are masking the information from the stakeholders in the trial. It can be a patient, it can be the investigator, it can be the statistician, or it can be even the those who are assessing the outcome. That process is called it as blinding. Means you are masking the information about whether that patient is receiving the intervention drug or control drug. So if you are not masking any information, all are everyone is knowing about which drug or which intervention he is receiving. So then that is called as open label. So when the participants are only blinded, then it is called as single blinded randomized study. When the participants as well as the investigator is blinded, then it is called as a double blind randomized controlled trial. When the participants, investigator, outcome assessor, and statistician is blinded, then it is called as triple blind randomized controlled trial. So there are multiple levels of blinding. Always triple blind is having better advantage than all other randomized controlled trials. But sometimes you will not be able uh, uh, to what I could say mask the information. So sometimes I say one example of surgical intervention. So surgical intervention, many times we cannot mask the information because patient is already undergoing the surgery. So he will be knowing I am receiving an intervention. So you can't mask in that case. So sometimes you have to be lenient. I can't tell that always you should have to follow triple blind or double blind. So it depends on your intervention. There will be the blinding will be chosen. So that is very important. You need to take understand of that always. Okay. Then there is something called a single center or multi-centric study. So single center means always a single center will be involved or one study site will be involved in a trial. That is referred as single centric study. Multi-centric means multiple centers will be involved in a study, and this multicentric can be from within a single country or in different countries. So if it is from a single country, then it is called as national multicentric national activity, and if there are multiple countries are involved, then international multicentric study it will be called. So it depends on the situation. You will be having naming in a different names. So placebo control, like I said, I was talking about the comparative. So I said you that the comparator can be placebo or it can be any other treatment or no treatment. So whenever you are using a placebo, then it is referred as placebo controlled RCT. That is called as placebo controlled RCT. Otherwise, we don't call it as placebo controlled RCT. We say that just it's a controlled trial. We don't say it's a placebo control. If you are using placebo, then you can term that as placebo controlled trial. That analysis patterns, so there are so many analysis patterns. Sometimes you can use a per protocol analysis, you can use the intention to treat analysis, you can use the missing data amputation. So there are multiple analysis will be involved in an RCT. It's a bit complicated. So you need to have some more biostatistical understanding to understand what are the different analysis which we'll be using in a randomized controlled trial. Now, the observation studies or the cohort studies. So it's very important. Observation studies you should understand. There are different types of observation studies. Basically there are three types of observational study. One is cohort study, another one is case control study, another one is cross-sectional study. This cross-sectional study you need to understand very importantly. Okay. Now I'm talking about the cohort studies. Cohort studies means Cohort means it's a single group which is having similar characteristics. It's a group which is having a similar characteristics is called as cohort. So if you are having a group of people and you are starting the study today and you are following the participants in future, that is referred as prospective cohort study. I think I have another slide which is clearly talking on a cohort study. So you can see here. So if you are starting your study today and you are following the participants into the future, you're following the participants into the future, then that is referred as prospective cohort study. So today I'm starting a study. I'm just analyzing some obese participants and non-obese participants. So those are all other similar characteristics are similar, only the exposure is different. So here the exposure is obese. So what I'm doing, I'm just analyzing right now. I'm following them to the future, and then I'm deciding whether there is a chance that these participants will get the disease or not. That is referred as prospective cohort study. Suppose I'm doing the same study, but what I'm doing, I'm taking all the data previously, whatever already happened from last 5 years data I'm taking, then I'm checking what happened in 2015. Suppose I'm taking the data from 2015 to 2020, and I'm analyzing whether they had this obesity or any other problem in the 2015, and did they get the disease in 2020. So there also my way of studies cohort, but what I'm doing everything in a retrospective, then that is referred as a retrospective cohort study. There is another design which is called as ambispective cohort study. Ambispective cohort study will be a mix of a retrospective study and prospective study. So that is referred as ambispective study. So the advantage of cohort study is ethically safe. Ethically safe means you are just observing the participants. You are not doing anything interventional in nature. So since it is just an observational study, it's comparatively safe in terms of ethics. The subject can be matched, and you can establish a timing and directionality of the event. Timing and directionality of the event means, suppose you are following the patient for 5 years, sometime some outcome will be happening after 2 years, some outcome will be happening after 3 years, some outcome will be happening after 4 years. So what you can do, you can see how that disease pattern is going on, how when they are getting the outcome. So you can definitely design how much time it will take to develop that particular outcome. So that's how that timing you can measure, or sometimes we call it as a causality assessment you can do here. Then eligibility criteria and standardized outcome assessment will be there in the cohort study, and it's easy to administer compared to the RCT. So it is having its own problems, but still it's easy compared to the RCT, because in RCT ethical issues will come, so many other problems will come. But here it's comparatively easier than RCT, as well as comparatively cheaper than RCT, because you are just observing the participants. You don't have to do any test from your own. You don't have to give any drugs from your own. So it's just an observational study. So it's comparatively even cheaper than the RCT. So other problems, or the disadvantages, getting control may be difficult sometimes, because you have to match the exposure cohort as well as the control cohort. So matching them will be a difficult situation sometimes. Then sometimes the exposure may be linked to a hidden confounder, because confounder in the sense, suppose you are analyzing, suppose I say for example the obesity and the outcome, right? So that obesity only may not be the reason to have that particular outcome. There will be some other factors. These factors we call it as confounders. So sometimes the effect of confounders will be there. So that is another problem. Blinding is difficult since you are just observing the participant. Blinding is not possible at all. Randomization is not there. And for rare disease, you need a large sample size, as well as sometime some outcome you may need long follow-up, especially these kind of cardiac diseases, or sometimes some outcome which is very rare. You may need a long follow-up when you choose a cohort study. So these are the basic advantages and disadvantages. Actually, in this session, I'm just touching upon exactly what it is. I'll not be giving very in-depth information, but whenever you have any queries or you have any doubts, always you can reach out to us, either to me or even you can write into fcpa.official@gmail.com. We are happy to respond you back with more examples. So here, this is a one example of very famous Framingham Heart Study, which is a one of big cohort study which started way back in 1948. It's a long study, and they are identifying multiple risks, multiple exposure, multiple outcome, multiple different things from this study. So it's happened way back in 1948. Now it's even reaching to the 2009, and recently there was some 2024 paper on Framingham study. So basically, there are this is one of the good example I could give you. If you are really interested to learn more about these cohort studies, you can go back and you can check what it is there. See, there is the first one. You can see that from 1948 to 2014, there are a generation one. So they have said that physical examination, blood sample, and lifestyle related data collected approximately every other year. So then they are analyzing it with the outcome. You can see the outcomes down: cardiac CT, vascular tonometry, cardiac MRI. So they are finding out different outcomes from that. So you can read more of Framingham study and it will give you a good understanding on what is exactly a cohort study is. Okay. Then case control studies. The difference between a cohort study and a case control study, there are majorly two, three differences. One difference, case control will be always retrospective. Case control cannot be prospective. So understand that case control will be always retrospective. And the cohort study, what we did, we started from an exposure and we moved towards the outcome. But in a case control study, always we will be starting from a outcome and then we will be going to the exposure. So that is the difference between a case control study and a cohort study. So two difference majorly. One difference is that case control study will be always retrospective. Second one will start from the outcome and will go towards the exposure. So, but in the cohort study can be a retrospective or prospective. Sometimes it is a ambidextrous also. But cohort study will start from exposure to the outcome. And the advantages of case control study, it can be quick and cheap, only feasible method for very rare disorder. Because I said you that, see, sometimes if you are taking an outcome which happens maybe after 10 years, if you are planning for a cohort study, you have to wait another 10 years to get that outcome. But if you take a case control study, you can see last 10 years what happened. So it's very easy for you to have a case control study for those rare exposures as well as a rare outcome. So that is the advantage of a case control study. Then you can study multiple possible causes, multiple possible exposure of a particular outcome. Then fewer subject is required than the cross-sectional study or the cohort study. So these are the few advantages of the case control study. But the disadvantages, as I mentioned, recall bias. Recall bias means sometimes if you ask some information from uh, the participants, if they may not be recalling, if you ask them, did you smoke 10 years back? They may not be able to tell. Sometimes they'll be able to tell that they smoked 10 years back, but they may not be able to tell that how many packs of cigarette they were seeing or they were just having during that time. So that is another problem. Then the other issue is that sometimes you'll miss the records because you are going retrospectively. Last 10 years back, that records may not be available for you. So that is another disadvantage of a case control study. Then selecting control group is very difficult sometimes, and sometimes there will be potential bias of selection of participants as well. So these are some advantages and disadvantages of a case control studies. Then cross-sectional studies. Cross-sectional study is the third type of observational study. So basically in a cross-sectional study, neither you will follow, neither you will take the data from retrospectively. You will be taking a data in a single time frame. Suppose I'm doing a cross-sectional study now. I'm doing cross-sectional for study for another 6 months. So I'm taking that 6 months as my time frame, and I'll be analyzing what is happening in that 6 months. I'll be analyzing my exposure, outcome, everything in that single framework or time frame. Then it is referred as a cross-sectional study. And these cross-sectional studies are called as otherwise sometimes ecological study, or sometimes we call it as prevalence study also. So it's very easier to conduct because you don't have a follow-up, you don't have to check the previous records, you don't have to get much information. You need to focus only on one exposure, one outcome. But sometimes you can do an analysis also here. So if you're doing an analysis, then it is called as quantitative cross-sectional study. If you're not doing any analysis, you are just doing a description in nature, then that is referred as descriptive cross-sectional study. So there are some more information you need to learn about cross-sectional study. So these are the basic understanding about a cross-sectional study. Then case reports and case series. So case report is the first level of evidence in the human clinical researches. So it is basically a single report of a single patient about anything. Sometimes it will be a rare outcome, rare disease, rare ADR, or it should be unique, something unique. So suppose I say one example in 2019 December, we had the first case of SARS-CoV-2 or COVID-19. So that was unique case that time. So basically anything which is unique, which is rare, which is happens like very uniquely, then you refer it as a single case. That case when you are publishing, that is referred as a case report, or sometimes we call it as case study also. So case report basically is an descriptive data of a single patient who is experiencing from a unique case. So that is case report. So, but this is very important. This is very important because this is the ultimate uh, evidence or the spark where you can get the new hypothesis. You will be getting new ideas. You will be expanding this case report into the case series and all other study designs. So basically, case reports are the basic nature of clinical research. So basically, it is very important. So case report is having so many advantages because it will be generating the hypothesis, or sometimes we call the signal detection also. So basically, case reports are signal detectors. Then it will help you to plan your studies in the future studies. Maybe sometime this case report can be converted into a case series, then further can be converted into a co-observational studies as well. So yeah, that is about case reports. And when it comes to a case series, it is like that is also descriptive study. But what you are doing in a case series, you will have a register of cases, maybe around 6 to 7 cases or 10 to 15 cases. Usually, it depends on the data. Sometimes even I have seen a case series of 168 participants also. So it depends on the researcher objective or depends on how we want to present the data. You can have the case series. So basically, we say that if anything more than 2 or 3, up to maximum of 10 to 15, we classify them as a case series. But like I said, even I see in the JAMA papers or any JAM papers where there is a case series of more than 100 cases also. So it depends on the researcher. But it's basically a collection of different cases, but it is have a similar characteristic. Like I said, coronavirus disease. So there was a first one case report, but later there was a case series of 10 to 15 reports in a single place, maybe one place. Or there are sometimes clinical case reports or geographical case series. Clinical case series means suppose I am a clinician or I am a healthcare professional. In my experience, in my clinic, there are suppose 10 cases which is having the similar characteristics. If I'm reporting that, that is referred as clinical case series. The geographical case series means I'm taking a geographical area. Suppose I'm taking a part of Karnataka. So I'm taking the different unique cases on a particular topic in that particular geographical location. That is referred as geographical case series. So both clinical case series and geographic case series having its own value. So it depends on the research question. So that is about the case reports and case series. Then I said you. So these are the basic. I just give you an overview of systematic review, narrative review, then meta-analysis, RCTs, observational studies, cohort studies, case control studies, cross-section studies, case reports, and case series. Now the thing is that you can choose any study design depends on your research question. But before you incorporate that evidence into your practice, because before your evidence-based medicine becomes your evidence-based practice, you need to check the risk of bias. You need to check the critical appraisal of that article before you incorporate that into any guideline, or before you incorporate that into any clinical protocol, or before you incorporate that into your practice. You should do a risk of bias assessment or critical appraisal of that particular data or particular evidence. So when you do a risk of bias assessment, when you do a critical appraisal, there are multiple key points which you need to check. That include the study design, like I said, an example in this chart, right? You need to clearly go through the study design, whether it is an RCT. If it is an RCT, whether it is a blinded RCT, non-blinded RCT, is it a randomized one? It's a non-randomized one. So you need to have proper design, proper criteria on a study design. So you need to check which study design they followed, whether the study design which they followed is appropriate for that research question or not. So you should have a proper critical appraisal of study design. Then there are key methodological features, like I said, whether they have included the participants from the same population, or whether they have taken it in a proper way, whether they have done the allocation properly, blinding is done properly or not. So you need to have the proper key methodological features. Then suitability of statistical measures, like I given some example in that slides, right? per protocol analysis, intention to treat analysis, modified intention to treat analysis. We have missing data amputation. We have per protocol analysis. So like that, there are multiple analysis. So I need to go through the statistical methods which they have done it properly or not. Then how they are interpreting the findings, whether their interpretation is accurate or not. Is there any problem with their interpretation? Then there is any potential conflict or not. More of that, after doing all these things, you need to check whether that particular evidence is really useful or relevant for your own practice. You can't always take the evidence and directly start with your patients. Not possible. What you need to do, you need to check the relevance. You need to do some adjustment. Suppose the say simple example I'll give you. See the age restrictions or the kind of, suppose you say elderly. If you go for any US guidelines or any other guidelines, they may take 65 as an elderly population, but we Indians we take 60 as an elderly population. So you need to be very clear, very concise, very accurate when you translate the evidence from a evidence-based medicine aspect into your practice. So there should be some adjustment to be done. Along with that, you should be checking whether whatever the evidence they have done, whether it is really matching with my patients or not. Am I really need to translate that evidence directly into the patients? Do I need any adjustment over there? So that is very important. So you should really get through whether that relevance is there in your practice or not. So all these are some important parameters when you do a critical appraisal of a research article or the evidence, research evidence. Then there are multiple types of evidence. Some type of biases like selection bias, performance bias, detection bias, attrition bias, reporting bias, and other bias. I'm not getting into this because it's very in detail. I need to discuss on that. Maybe in the future classes we can plan something on that. So, like I said, I will just show you some tools for the different risk of bias assessment of different study design. Suppose you are doing a risk of bias assessment for the systematic reviews or meta-analysis, you can use a tool called it as risk of bias in systematic review, ROBIS tool, or you can go for Amster 2 checklist also. So these are the two authentic or highly used tools for checking the risk of bias in systematic reviews. Suppose you are checking the risk of bias in a RCT, you can use Cochrane Risk of Bias Assessment tool. And now we have Cochrane Risk of Bias Assessment tool version 2, ROB2. You can use ROB2 also, or you can go for Gerard scale. You can use JBI tool. You can use CASP checklist. You can use Pedro scale. Whichever you are familiar, whichever you are comfortable, more comfortable, you can use it. Okay, but you should be clearly defining it properly. You'll be using it in appropriate way. Otherwise, your interpretation will go wrong. So these are some scales which you can use to assess the critical appraisal or methodological quality of a RCT. When it comes to the non-randomized interventional studies, you can use CASP checklist, critical appraisal special checklist. You can use CASP checklist, or you can use NIH tool. You can use the Robbins one risk of bias in non-interventional studies. You can use, or you can use minus tool. You can use Downs and Black checklist. So these are the some tools which is there for non-randomized interventional studies. So if you are using any kind of observational studies like cohort study or cross-sectional study or case control study, you can use like NIH. Obviously, NIH, CASP, JBA is there for all the different study design, but you can use SIGN tool, you can use NOS tool. So Newcastle Ottawa is one of the best tool which you can use for any observational studies. Then when you are doing any critical appraisal of a diagnostic studies, you can use CODAS tool, you can use CASP checklist, or you can use even SIGN checklist. If you're using anything like prognostic studies, you can use TUPS checklist. Or if you are doing something on case series and case reports, you can use the tool which is developed by Murad et al., or you can use the JBI tool, or you can use the CASP checklist. So there are multiple tools. Okay, I can't say that always use this tool. That depends on your research question. That depends on the suitability to your research. So you can use any of the tool. I just give you some list of different tools which you can use for the critical appraisal. Whenever you do an economic evaluation, you go for a GRACE checklist, or you can go for a NACE checklist, or you can go for even JBA checklist also. So there are multiple other tools. Okay. When you do a qualitative study, you can use the quality framework by cabinet checklist, or if you have correct checklist, you can use any other tools also. These are the some list of tools. Randomly, I just chose some tools and I provided you a list. Okay. Now, this is very important. It's not only the methodological quality. As I mentioned, risk of bias will be always discussing on the methodological quality, but there is something called as reporting quality. Methodological quality is different, reporting quality is different. Methodological quality means how they conducted the research, whether they have done it properly or not. Is there any bias in that? Is there any problem with their methodology? So that is called as risk of bias, or that is called as methodological quality assessment. This is reporting quality. This is reporting quality means though they have done it properly, whether they have reported it properly or not. For that, we follow always Equator Network. Equator Network means enhancing quality and transparency of health research. So we'll be always using Equator Network. And then if you go to the website of Equator Network, you can just type Equator. So you'll get the all these different types of uh, tools which you can check the reporting quality of the studies. Suppose I'm doing a RCT, I should follow the consort diagram. If I'm doing something on observation study, if I'm publishing an observation study, if I am going to publish my study in a good journal, I should follow the STOP checklist if it is observation study. Suppose I'm done a meta-analysis, systematic review. I should follow Prisma checklist. So these are the some tools, reporting checklist, which is available to report your study. And you should follow this very important. You should follow any of the checklist. So if you go to the just Equator Network, suppose sometimes you will not be able to know, you will not be knowing which reporting checklist I should use for reporting my study or while I publish my study. So what you can do, you can go to the Equator Network. You can choose. You can see the downside, right? There is a you can just choose which study type you want to use. Suppose I want to report my studies in a observation study. So I just choose observation study. Then they will tell you which tool you need to use. So maybe in the future, when you publish any of your paper, you can just check Equator Network and you can get through which tool you should be using to report your findings. So that is very important in the reporting a research tool. If you follow this 100%, your research will be having all the aspect to publish a paper. But if you're not following, sometimes you will miss some information. It will be mismatched or you'll be reporting somewhere else. All those things may happen. So I always recommend to use any of the reporting checklist to be used while you publish your study. So that's very important. So that's all about today's session. So I just give you a brief idea on what are the different study designs which are available, and I given you a list of different risk of bias tools. I know that it's very less information, but maybe in the future classes we can think of having in depth of each tool how to use and but right now I just give you some insight on what are the different tools which is available for the risk of bias assessment. Then I give you an idea on how to report your findings. So I recommend you to use all these tools, all these things while you do your research, while you interpret your findings, while you get into the research. All these things are very important. So hopefully FCPI and the Research and Publication Forum in the future can provide more insight on the different clinical research aspects and other things. Okay, so I would like to conclude my session. It's exactly 5 minutes left from now. So I just give you some announcement that in the future on the 31st of May, we have our cycle one presentation by critical forum, and they'll be talking on anaphylactic shock. Dr. Hafiz from he's an assistant professor at Adichinchanagiry University, and he'll be talking on anaphylactic shock. And then we have another session on June 7th by Arya S. Kumar on antibiotics intravenous to oral switch. How you can switch the IV to oral. So she'll be talking more in-depth knowledge on that. And then on June 15th, we have antimicrobial loading dose and maintenance dose concept by Dr. Said Luganda, and he'll be talking more of like, how to design a loading dose, how to convert that into the maintenance dose, what are the different parameters like PKPD parameters and all other aspects when you decide your dosing. So on June 5th, we will have a session on that. And thank you so much for joining today. And if you have any queries or question, please post to us and we'll be happy to help. And these are all our social media which you can follow, and you will be getting a regular update on what the different sessions are going on, what is happening with the FCPA platform. So thank you so much for joining today evening, and I would like to hand over the session to the moderator.
Thank you so much, sir, for this informative session. Sir has discussed about different study designs in the clinical research, its method, and the advantages and disadvantages of the study designs. Sir also explained about the risk of bias, the types of bias, and various risk of bias assessment tools. I hope all the participants enjoyed the session and have gained some knowledge related to the evidence-based medicine. Before winding up, I would like to remind you all about the feedback about the session. So if you're providing the feedback before the live session is ending, it is very well and good. And I thank everyone to joining this session. And once again, thank you, Rashid sir, for providing such a wonderful session. Thank you, sir.
Thank you so much.